Pediatric bariatric surgery is a very hot topic nowadays because there has been a paradigm shift in the way of thinking and approach to treatment of pediatric obesity. In this presentation, I'm gonna give you an outline about facts about pediatric and adolescent obesity and new guidelines and indications for the treatment of pediatric obesity, recent innovations in surgical intervention, and current and future scholarly output in this field based on extensive literature research which I have carried out in the past few months. So why is it a hot topic? As I mentioned earlier, children are the fastest growing segment of obese population. Usually obesity, especially grade 3 and 4, are refractory to conventional methods of weight loss, and surgery is regarded as the most effective method in those two types. There is no other way of treating the disease so far. There are about 400,000 deaths per year from this disease. For children, it is believed that for children with a BMI above the 99th percentile at the age 10, 88% will have a BMI more than 35 as an adult, and 65 will have a BMI more than 40 as an adult. So an early intervention is important. We don't have to delay this intervention, and this will be clarified more in the upcoming slides. Childhood obesity has severe implications on all the body systems, mental health as well, pulmonary and body systems as regards the pulmonary, GIT, renal, musculoskeletal, cardiovascular, neurological, and endocrine. So, and of these comorbidities, type 2 diabetes is one of the most significant. 1/3 of healthy toddlers are at risk of developing diabetes. Medical treatment shows poor response in those patients, and surgery may completely reverse diabetes in adolescents, and this will be highlighted in the papers which I will share with you in the upcoming slides. There is a very strong indication for metabolic surgery in adolescents because at this age the response to there is a better metabolic response to these kind of surgeries, because there is a term which really grabbed my attention. It's called the metabolic plasticity. So the earlier that we intervene with those patients, the islet cells, the islet cells which produce insulin are less likely to be consumed. But the longer that we wait to intervene, these islet cells will be burnt out, and diabetes will be more resistant. It's not going to be easy to treat. Other comorbidities include pseudotumor cerebri that may originate behind. Pseudotumor cerebri is a very odd condition. It presents as headaches that may originate behind the eyes, can make the patient up from sleep. It can worsen with eye movements. It's associated with ringing in the ears that pulses with heartbeat, nausea, vomiting, blurred vision. And in these cases, MBS or metabolic surgery is the best treatment. Cardiovascular disease as well, because increased BMI during adolescence lead to increased risk of dying from a heart disease. So that's why we really need to consider strongly metabolic surgery. In the United States, 1 of 3 children are overweight, and 1 to 6 children are obese. So if this trend doesn't change, 2 out of 5 girls will develop type 2 diabetes in their lifetime, and 1/3 of boys will develop type 2 diabetes in their lifetime. In addition, of course, to the high percentage of those children who will have high density lipoprotein and hypertension, cardiac risk factors. The estimated annual healthcare costs of obesity-related illness are about 190 billions altogether. Childhood obesity alone is responsible for $14 billion in direct medical costs. The best treatment for adolescent obesity is surgery. Yes, dietary and behavioral treatment can be sought, especially in the type 1 and type 2, but if it is applied to higher grades like type 3 and 4, it's associated with a high dropout, poor compliance, low success rate, high recurrence, and it's also not widely available, and it has a very poor insurance cover. Surgical therapy is the most effective at long-term weight loss, and it's also very effective at resolving comorbidities, as I will show to you in the upcoming slides from literature. So it is a metabolic problem. Obesity is a metabolic and endocrinal problem. So ghrelin, these hormones, ghrelin, it increases our appetite. Leptin and tyrosine peptide, they lower our satiety. So when we carry out a surgery, we don't only cut off or reduce the stomach size so that we reduce the amount of cake. We also take off the cells in the fundus which produce ghrelin, which is responsible for our hunger and wanting to eat more. So it's also like some sort of an endocrine intervention, not just a surgical intervention. Without surgery, when people lose weight, they do lose weight, and beyond a certain point they start to regain weight, and this has been noticed. And so at the weight loss is ideal at week 10, and then they start to build back the weight that which they have lost. So this is on dietary management alone, and there has been an explanation for this weight regain. Ghrelin, it said, rises higher after eating when dieting. If we are on diet and we start eating, it makes us more hungry. So we eat more, so we try to make up for the lost weight that we have managed to get rid of. The tyrosine peptide decreases when dieting, which usually makes us less satiated. So obviously we don't feel satiated enough and we keep on eating. So surgical intervention, as I mentioned earlier, does not interfere with the amount of food intake. It also interferes with these hormones. It's like an endocrine intervention. Gastric banding is been used in bariatric surgery, but it's not FDA approved in adolescent surgery, so I'm not going to talk about it. The Roux-en-Y gastric bypass is widely used in very high BMIs. Really encourage using it for fear of malnutrition. Although there are certain indications for this kind of surgery, especially if there is reflux, and there are special indications for it. However, it's not widely used in pediatric surgery. On the other hand, sleeve gastrectomy, which has started as the first stage procedure of Roux-en-Y, but hasn't been completed because of in high risk patients. It avoids the bypass part, but it resects part of the stomach. It's associated with significant weight loss, no enteric anastomosis, no mesenteric defects, no vagal injury. It's very suitable in adolescents and growing children because there is no risk of malabsorption as with the Roux-en-Y. And if it fails, it can still be converted to Roux-en-Y because, as we said, it was the first stage of Roux-en-Y. There are some papers about the sleeve gastrectomy in uh, adolescent age group, and I would like to share this with you. This paper, for instance, it describes this paper. It's just one to. This paper is by a group. They managed to publish about 38 patients and follow them up over a period of 12 months, and look up the improvement in their comorbidities, which included type 2 diabetes, hypertension, dyslipidemia, and fatty liver, and obstructive sleep apnea. It has been associated with a significant loss in of a significant weight loss, about 40%, 47, 44% in a period of 12 months, and resolution of the majority of the comorbidities. In an even larger cohort study, which is 242, with a relatively longer follow-up period, which is 3 years, they have reached similar results as regards the resolution of comorbidities, type 2 diabetes and the pre-diabetes, dyslipidemia, and the blood pressure and the kidney functions, with a remarkable improvement in such comorbidities. When comparing the labs of those patients who carried out surgery to those medically treated patients when treating type 2 diabetes, there are remarkable improvement in the group who carried out surgery, as well as improvement in insulin resistance, and the triglycerides has been lowered remarkably, and less renal injury compared to those who were treated medically. There are other papers comparing the sleeve and the bypass patients over a 5-year period, and there has been both group has shown equivalent reduction in BMI, equivalent improvement in the quality of life, as well as equivalent improvement in comorbidities. But on top of that, the bypass the sleeve patients had lower level of vitamin deficiencies, and this is more important because, as we know already, that pediatric age group are still growing and they need those nutrients. When comparing adult versus adolescent sleeve gastrectomy over a follow-up of a 4-year, it was shown that adults had more comorbidities. The percent of total body weight loss was higher in adolescents than in the adults, and the comorbidity resolution was higher in adolescents than adults. And this study shows the significance or the importance of starting earlier, treating obesity earlier in childhood, even younger than the age of 10 years, as I will show you later. As regards the guidelines, the barriers that were placed earlier to bariatric surgery, that preoperative dieting is a must, failure of dietary is a must. No, it's not there anymore. There is no data showing different outcomes. The Tanner stage, there is no data to show delayed development. Bone age, even it only data, single study shows that there is an improved in linear growth with surgery. Guidelines, age 10 to 19 considered routine. Younger ages are even considered. Even some people have reported at age of 4 years as well. Other contraindications which have been lifted: depression, eating disorders, history of trauma, unstable family situations, autistic spectrum, syndromic obesity, developmental delay, children unable to assent to surgery. So all these contraindications have been removed. We don't choose the term BMI. We don't choose only the BMI measurements in measuring or as an indication for surgery. We use the term BMI cutoff, which is based on the gross charts of the which is based on the gross charts. So gross charts. So we use the term instead of BMI 40 or BMI 35, we use 140% of the 95th centile, or 120 for the 40 BMI, and for the grade 3 35 BMI we use the 120 percent of the 95th percentile. And this is important for a reason. In this slide, which is really very important, it explains, shows an example, a patient who had a BMI of 32 kilogram per meter square, and his relative percentile was 143% of the 95th percentile. So according to the BMI, there was no indication for BMI on its own. There is no indication for surgery, and herein the doctors would say we will wait and try medical treatment and see how he will improve. On the other hand, if we look up the relative percentile, which is 143% of the 95th percentile, we'll see that this is almost equivalent to a BMI of 40, which is a strong enough indication for surgery. But in this case, the patient was left for 5 years until he reached a BMI of 50, equivalent to a relative percentile of 176, which is way higher than grade 4. So they waited too long for surgery, and the patient at that point, when he was 15 years old, did carry out an operation, and he did lose weight, but still the amount of weight which was lost he's not going to be the normal weight. He's still going to be overweight. But if he had surgery early on, when he was 10 years old, he would have lost the 15 BMI units, and he would become a normal weight child. Usually, it's an interesting observation in bariatric surgery. When they do surgery, there is a limited or a fixed BMI points which are lost, which is about 15. So if they started early, he would have reached a normal weight. But an overweight, if you start way overweight, still there is some way to go. So this is an interesting observation, and why it is important to use the BMI cutoff points. So I think this is probably enough for this point. In the next slide, there are more evidence and best and guidelines. So BMI, it's not the age which is the indication for surgery. Class 2 obesity, BMI is more than 35 or 120% of the 95th percentile for age and sex, associated with a comorbidity. And class 3 obesity, a BMI is more than 40 or 140 of 95th centile, and there is no need, and not a comorbidity doesn't have to be existing for surgery to be carried out. So I'm coming close to towards the end of this presentation, and so there is a usual obesity treatment pyramid, which starts with dieting, physical exercise, followed by pharmacology, and surgery comes at the end. But and there are algorithms for this, but nowadays the pediatricians have a lower threshold for referring patients with BMIs. In the past, a BMI of 40 for adults, and adolescents and children, the BMI had to be over 50, and has to be 40 with comorbidities in children, adolescents. The cutoff point was put or the bar very high for children compared to adults, but this bar nowadays is becoming lower and lower, and thanks to the BMI cutoff, which is based on the graphs, it has become easier for medical doctors to evaluate and evaluate those patients and to decide when this patient should operate. As with anything in the world, in order for it to be successful, teamwork is very important. Teamwork is very important. I always tell myself that a lone surgeon is a very dangerous surgeon. So metabolic and bariatric surgery goes the same. And because of the high risks and the high morbidities associated with bariatric surgery, teamwork is very important, and everyone has a very high significance in this team. So a multidisciplinary team approach in metabolic and bariatric surgery should comprise a pediatric obesity specialist, a surgeon, nutritionist, psychologist, adolescent medicine, GI specialist, cardiologist, social worker, program coordinator, and there has to be a program, an accredited program. And there has been very wide discussions about a program which trains doctors in surgery. So in accredited program, adult program says that in order to have an accredited program, you should have a flow of 50 patients per year. But in pediatric, it has been agreed on to come down to 20 and even less, 20 patients per year. So the number is going down, but there is, just to let you know, that there are talks about what makes a program accredited. These are programs from different centers I would like to talk to you about. So there are pre and post-operative weight management program. It's designed to improve eating, activity habits, participate, set monthly goals for lifestyle change, run pre-op and post-op on a rotating schedule, meets a minimum 3 months pre-op and 3 months post-op. Pre-op lifestyle intervention. So if a surgery is being carried out, the post-operative follow-up is very important. And obesity as well is a lifestyle problem. So those patients has been binge eating. Their lifestyle have been very much affected by their weight. They cannot just go to the gym right after having an operation. They will need a physiotherapist to tell them and to show them how to use their body properly, because if they go directly to the gym, they might suffer injuries and suffer other things, and it's very important for a physiotherapist to be around, and nutritionists to teach them and educate them on how to eat and drink properly. Telehealth as well, because of the corona pandemic which happened, the COVID pandemic which happened 2 years ago, it has drawn on our attention about the importance of telehealth, and because this has saved a lot of time, transportation, and transporting and energy. So Zoom meetings can be carried out more frequently. All group visits via Zoom. Each patient is instructed to purchase a scale, water bottles, it's a pill box for their vitamins. Water is very important to hydrate patients. A colleague who had a bariatric surgery, and he himself suffered severe dehydration during fasting Ramadan, and he caused a thromboembolism and that affected his lung, and thankfully he was saved. But hydration is very, very, very important, and it's very important to educate patients on this. There is a very huge role for enhanced recovery after surgery in bariatric surgery by following special diet to shrink the liver, to introduce certain medications, no Foley catheter, no drains, anesthesia, not to use heavy sedation and PCA narcotics, to avoid nausea, aggressive nausea, and to control it with Zofran, Activan, and other medications, early ambulation and ambulation and discharge on a 2-week liquid diet. So there is a huge role for ERAS in bariatric surgery. There are some quality improvement projects that's been carried out to improve the quality of life for those patients. There are pilot studies for patients who have failed weight loss following this surgery using and to introduce medications for those patients to have them lose weight. I thought I should share it with you just to get an idea. There's also a database, because we all know the importance of clean data. Data is very important. Data is the future of medicine. This is how we are gonna build our evidence. And when it comes to decision making, they found out that only 3% of our decisions is based on on evidence based from literature. The remainder is on experiences, but probably in literature is full of data which is shady, doubtful. So data is very important, and this is a database which I would like to share with you in case you would like to share your data in this database, to this database as well. Before I go on to the honorable mention, these are the last 2 slides. I would like to say that there are talks about introducing bariatric surgery programs in the States, more pediatric bariatric surgery programs, but there are talks about why it's limited, because the number of surgeries carried out are still few per year, less than 15, but it needs to go up to 20 at least to have an established pediatric bariatric program. Pediatric patients need a special treatment. If you have a pediatric patient, he cannot be looked after by just an adult doctor. He needs a pediatrician on the team. Pediatric surgery, bariatric pediatric surgery, they also need a pediatric surgeon, but pediatric surgeons are not until 2 years ago were not very interested and keen on bariatric surgery, but now there is an increased interest in pediatric bariatric surgery by pediatric surgeons, special handling of these patients. Some adult surgeons stated that they are not comfortable doing pediatric surgery to operate on pediatric patients. So there are probably something related to just handling the tissues between adults and pediatrics, which is beyond the scope of this presentation. Another honorable mention, a recent study which has been just published 28th of April this year, long-term outcome of sleeve gastrectomy in adolescent patients, the effect of weight loss in younger years to outcomes in adulthood, which is probably one of the longest follow-up papers on pediatric adolescent surgery, and it's a very good read, and it's published on BMC surgery. Another paper, which is outcome of bariatric surgery for patients with prevalent inflammatory bowel disease, a nationwide registry-based cohort study. It's not related particularly to pediatric surgery, but I'm just getting bigger. It's like we can look into the impact into many other things, inflammatory bowel disease. Now I've reached the conclusion of my presentation. I just want to say that pediatric surgeons now are becoming interested in bariatric surgery. There are more and more pediatric surgeons who are carrying out bariatric surgery. And bariatric surgery is not just surgery. There are other things that you need to put into consideration when working in this field. The thing which I haven't covered, the selection of the operation. As I said, yes, sleeve gastrectomy is the most used operation in pediatric age group, but there are still debates about whether to pick up this operation if the patient has reflux disease, whether it's better to do a Roux-en-Y and other things. when to consider doing the upper GI. Does it have to be done routinely, or so there are so many things that are involved in this field that we need to think about. As with anything in surgery or any other procedure in surgery, bariatric surgery is not just cutting the stomach and reduce the food intake. It's more than that. It's like an endocrine surgery. It affects the way not only the people eat, how they think and feel about their bodies.